Hello, everyone, and welcome to our webinar. My name is Tracy Cook with Sachs Healthcare Communications, and I'd like to show our audience today how you can send in your questions throughout the webinar. Our speaker will try and answer as many as possible at the end of the presentation. I'd like to introduce our moderator, Pat Poza. Ms. Poza is a Quality and Patient Safety Program Manager for the Adult Hospitals at Michigan Medicine. Pat has been involved in many quality and patient programs, including hospital and system-wide sepsis management. She has been the faculty for multiple state and national clinical collaborators, including the Surviving Sepsis Campaign Phase 4 Collaborative, among several others. Pat has published many articles in both clinical and quality journals and lectures and consults extensively nationally on sepsis, various critical care, patient safety, and quality topics. Pat, welcome.
Well, thank you, Tracy, for that kind introduction. The title of the webinar today is Sepsis, Are We Doing Enough for Our Patients? I'd like to introduce our speaker for this timely topic, Angela Craig. She is the clinical nurse specialist of the ICU at Cookeville Regional Medical Center in Cookeville, Tennessee. She's been a clinical nurse specialist for over 25 years, and the last 15 have been in that 28-bed ICU at Cookeville Regional Medical Center. She's chair of her hospital sepsis team and has led her hospital to be the first sepsis disease-specific certified hospital in the state of Tennessee. Additionally, she is on the Sepsis Alliance Advisory Board and a subcommittee member of a group called the Clinical Community Advisory Committee. She's worked in the area of nursing home, long-term care, and home health care, as well as EMS to increase early identification of sepsis and how to best treat it. Ms. Craig has spoken both locally, state, and at the national level on topic of sepsis and hemodynamics. Before we get into the presentation, I just want to review her disclosures. She's part of the advisory committee and speakers bureau for both Baxter and Beckman Coulter, as well as Edwards Life Sciences. And as said in her bio, she is part of the Sepsis Alliance Advisory Board member. How do you get CEs? This activity is approved for 1.0 CE. And you can see the accreditation statement. At the end of this webinar, we'll go through what you can do to get those CEs. And just a reminder that this activity is supported by an educational grant from Dale Medical. Now I'd like to turn the presentation over to Angela. Angela Craig?
Thank you, Pat. I appreciate it. Pat and I go way back. In fact, it's an absolute honor to have her be with me here sharing about sepsis because when I first started going live at my hospital, Pat was my mentor. She's still my mentor to this day, and we're good friends, and we collaborate about things we need to fix in our ICUs, etc. So thank you, Pat, for the long-term mentorship and friendship. And we're going to talk about sepsis. Are we doing enough for our patients? And this definitely is a timely topic. We have a lot to get back to the basics, right? Post-COVID, I think some of our sepsis numbers dwindled a bit. And so it's time for us to get back to the basics and really talk about what are some things we can do for our patients. So we are going to today talk about the latest guidelines and best practices for care. We're going to discuss monitoring strategies for our deteriorating septic patient, and then talk about maybe some new strategies or some strategies that maybe you guys have about decreasing readmissions of sepsis patients, because we know that is a large, high readmission diagnosis. We all know, I'm sure, the current state of sepsis. The current state of sepsis in the United States, each year at least 1.7 million adults in America develop sepsis, and nearly 270,000 Americans die as a result of sepsis. And I think one of the most dismal statistics in my mind is that 1 in 3 patients who die in a hospital has sepsis. So that's a very large percentage of mortality related to sepsis. There's also a major global burden of sepsis. A recent scientific publication showed that in 2017, there were 48.9 million cases and 11 million sepsis-related deaths worldwide. And so that accounted for almost 20% of all global deaths. So when you think about the global burden of sepsis, it's many times difficult really to ascertain, but it's big, it's a lot. When we think about the burden of sepsis across the world, it is quite a burden. So thinking about that burden, we want to think about some monitoring strategies for that patient who is deteriorating. And I wanted to share with you some of our strategies here at my hospital, and maybe you even have some as well. But I know that the people who tend to do the best, or the hospitals that tend to have the best statistics, are hospitals that have a system for real-time monitoring, something that is reliable, something to where you can get information that, hey, I've got a patient down in the ER right now that very well could be septic, and then trying to get down there and impact that care. That being said, I don't know about you guys, but FTEs are not just real easy for me to get at my hospital. And if they are in yours, enjoy it, because things have been a little rough financially, right, in the hospital setting. So we have to be creative. I don't have somebody who runs right down in the ER. I have multiple roles. I am the sepsis coordinator, but I'm also a clinical nurse specialist for 28-bed ICU. So there's many other needs as well. So I think it's important that everybody understands what sepsis is, having a very much a focus on education and screening and early identification, and then having everybody be aware versus just one person responsible. I've often said I don't want the sepsis program to be Angela dependent. I need everybody in this hospital to be working toward that same goal. So really making sure all staff understand the value of screening. That goes from the emergency departments to all of our units caring for patients. There are sometimes when I've gone to a hospital and I'm talking to people about their sepsis program, and I'll say, so tell me about how you guys screen. And they'll say, well, they don't screen in the ICU, but the other units they screen. And I'm like, oh, why don't they screen in the ICU? Well, everybody feels like the ICU nurses are just on it. Okay, and we may very well just be on it, but the reality is, how many of us get busy just with every day? We don't always stop and focus on that sepsis screen. So I really want to encourage everyone to make sure the staff understand what a good screening process is, and to screen every shift and PRN. Also, you can see that last bullet there, early warning signals through your EMR. I just want to challenge you that sometimes these early warning signals may cause some alert fatigue. Now, I'm not saying, don't misquote me, these are wonderful. However, there has to be accountability. You want something that's sensitive enough to where it's not going to alert every time to where people think, well, this is just not valid, it's not correct. So hold people accountable. When they cancel these alarms, you need to know why they're canceling them, and make sure you're able to track that. I actually like a hybrid approach. I think having early warning signals and having the nurses screen is really important, so they understand the process. And what I have here for you is just a copy of a screening tool, the paper version of a screening tool. Here at my institution, it's all placed electronically. When also thinking about monitoring strategies, we want to think about our emergency department. So an option could be, I don't know if you guys have this, but we tend to have backup in our emergency room. And sometimes we'll have 20, 30, 40 patients in holding. So we need at times to have a provider right down there in triage, and then go ahead and start treating these patients while they're in the lobby. If you notice that they have a known or suspected infection and they have SIRS criteria, and you're going to be getting blood cultures or getting a lactic acid, why don't you go ahead and get that while they're waiting out in the lobby? So hopefully you can start determining how sick these patients are. Another thing to think about are the latest guidelines that just came out in 2021. Now, we've had guidelines for a long time, and this just shows kind of the changes from 2012 to 2021. I'm going to focus primarily on the 2021 changes. And first of all, the definitions have not changed since 2016. And for this first part of the talk, I want to focus on initial resuscitation. Now, patients with sepsis-induced hypoperfusion, there is a suggestion that at least 30 ml per kg of IV crystalloids be given within that first 3 hours. And they also have suggested now using balanced crystalloids instead of normal saline for resuscitation. So order sets that might need to be updated with LR or Plasmolite or Normasol. Those are the three that are considered more balanced crystalloids. And in regards to initial resuscitation, notice in 2016, they talked about using dynamic resuscitation markers, a passive leg raise, targeting that MAP to 65, and then reassessing hemodynamic status to guide resuscitation and to hopefully normalize that lactic acid. There is no change in that in 2021, except for they do suggest using cap refill to assess resuscitation. I'm going to take you through a case study and talk to you a little bit about initial resuscitation and how you can do that to where we can individualize the care for the patient. This is just an example of a cheat sheet that we use here at my institution. So we want to look at our patients and see what it is that they need individually. So if a patient is hypotensive or hypoperfused in any way, then I want to monitor stroke volume. We have the ability to do that non-invasively, and so we can monitor stroke volume. We can do a passive leg raise or give them a small fluid bolus, and if they have a stroke volume increase of greater than 10%, then our thought is that maybe fluid could help with the hypotension or hypoperfusion. And we can monitor that. If for some reason my patient does not have an increase in stroke volume, then I know fluid is not the answer for them. So it really helps us to identify who can tolerate that and who can't. So we'll talk about that as we go. But let me just share with you a little bit about a passive leg raise. So basically, you start with your patient in a 45% degree angle in that semi-recumbent position. And then after the initial time period where you get some baseline data, then we're going to lay the patient's head flat and lift their legs. Now, this has to be done passively. And what's going to happen is that blood from the legs and the abdominal compartment will go toward the heart. And we're going to wait about 1 to 2 minutes, and then we'll reevaluate. And it does require a stroke volume measure. What I like about passive leg raises is that if for some reason they do not respond to fluid, or it looks like fluid is not the answer for that patient, you can just lower their legs and gravity should pull that fluid away. But there are a lot of studies about passive leg raises. This is just one meta-analysis. It's 23 clinical trials, and they found that the area under the curve was 0.95, very high percentage of predictability. So they use this with cardiac output or stroke volume measure to predict fluid responsiveness, and it found that it had a very high diagnostic performance in various settings. So it does work, it's easy, and I call it the poor man's fluid bolus, right? What's free in healthcare, but hey, we can do a PLR and not have to give them fluid, and then we can reverse it very quickly. Let's talk about the importance of volume optimization. There is data out there to support individualized care, and I put a few studies in here, but there are many more. One of the things in our bundle strategies for that hour one bundle, it says to begin rapid administration of 30 ml per kg crystalloid for hypotension or a lactate greater than or equal to 4. So let's think about our some other bundle strategies. So individualized care is essential. There is also a lot of focus, if you guys are presenting your CMS data every month, focus on documentation. If fluid seems detrimental to patients, then we need to document that. One of the things we've done here at Cookeville Regional is we've developed tools for our provider. I have included that in this next slide here. And we have this electronic, but in order to show you, I obviously have the paper copy that that's here. Basically a screening, known or suspected, surge criteria, organ dysfunction, but the next part is where we give them specific information that what needs to be completed within that 3 hours. We really like to get it done in hour one. But notice we've added a spot in here where people can document why they're not giving that 30 mil per kg, and then also how much they are to receive. We've also added a septic disease process communication part to that tool as well, so that we can show and document that we are speaking with patients and families about their septic condition and starting discussion about their self-management of care. But this is just a way to kind of help prompt the providers to know what is expected in their documentation. When I was looking through the literature, I happened to come across this article by the Surviving Sepsis campaign, and they are looking at fluid resuscitation challenges. I don't know about you, but this is one area that's probably that we fall out on a lot when we think about some of the core measure data. But I resonated with this article because you can see they're focusing on questions. What are ideal endpoints for volume resuscitation, and how should volume resuscitation be titrated? What is the optimal fluid for sepsis resuscitation? And what is the optimal approach to selection, dose titration, and escalation of vasopressor therapy? I think it's really important to start really looking at some of these challenges and how we can better optimize each patient individually. There's also data out there that talks about the long-term impact of fluid overload. And this was a retrospective analysis, 247 septic shock patients, and they found that a lot of the patients were volume overloaded, greater than 10% of admission body weight at discharge. 35% were volume overloaded at discharge from the ICU, and there was like an average 12.5 liter overload volume. And what they found was volume overload was associated with the inability to ambulate at discharge. Now think about that. If somebody could ambulate before they came in the hospital and they were not able to ambulate when they left the hospital, that's pretty detrimental, right? And also a greater percentage of patients were discharged to a healthcare facility, so they didn't go home. So this can be traumatic. This is a long-term impact of fluid overload. There's also long-term impacts of fluid underload. So of not giving the patient enough fluid. I don't have data in here for that right now. We could talk about just this topic alone all day, right? So I think it's really important that we just try to optimize patients' volume status individually. Now, this recommendations from the Surviving Sepsis campaign say if the shock is not resolving, suggest using a dynamic over static variable. Be used to guide or predict fluid responsiveness. And I think the take-home message is use a stroke volume measure, right? And I speak about hemodynamics too. It's near and dear to my heart. So I'm also just passionate about doing what we can for our septic patients. And it seems like so many of these patients meet the criteria to need hemodynamic monitoring. Now, if for some reason, there's different ways to measure stroke volume. So if you have an arterial waveform device, or if you have a totally non-invasive device, or if you are calculating it, if you have some numbers from your SWAN and you're doing a manual calculation of stroke volume, I think it doesn't really matter how you're getting it, just as long as you're getting it, doing it the correct way. So let's talk for a second about if you have an arterial line. I consider arterial lines less invasive than a pulmonary artery catheter, but it's still invasive. But we can get a lot of hemodynamic values from different systems with an arterial line. And so I just wanted to make sure that everybody's aware, no matter what kind of line you have, you always want to make sure it's leveled to the phlebostatic axis, make sure it's leveled appropriately. And I just threw in here a device to where you can actually put it on the patient's arm and it gets right to that area. You want to make sure that line is stable and has a good square wave test if you're using an arterial line. Here you can see this device we use that's very flexible, has a bendable area to it to keep your arm at the right place. I don't know about you, but if you're going to do invasive or less invasive hemodynamic monitoring, you've got to have a good crisp waveform and want to make sure it's got a good square wave test. And then we have the ability also to monitor non-invasively. There's different devices out there. I'm not going to go into that, but different devices. And I think my take-home message is this. There are people always want to say, hey, maybe it's not accurate in some way, shape, or form. You know, everybody's got their idea on what a perfect system is. And I think the most important thing is doing something. Trend is your friend. Doing something, knowing where your patient's at on their Frank-Starling curve, if we can trend it to have an idea on how they're doing and individualize the care. But doing nothing is not the answer. Okay, so moving on. So you can see also we've got some studies that have been done that talk about stroke volume guided resuscitation in our severe sepsis and septic shock patients does improve outcomes. In this study, they demonstrated stroke volume guided fluid resuscitation in patients with severe sepsis and septic shock was associated with reduced fluid balance and improved secondary outcomes. Excuse me, some of those secondary outcomes you can see here, length of stay was shorter, duration of vasopressors was less mechanical ventilation, and less likely to require acute hemodialysis. As well, I wanted to mention the FRESH trial. The FRESH trial is fluid responsiveness evaluation in sepsis-associated hypotension trial. And what this was, it found that dynamic assessments to guide fluid administration may improve outcomes for septic shock patients compared with usual care. And this study, a lot of this study was done in the emergency department. So this can be done in other areas, not just the ICU. Some of their endpoints were it had a decreased 72-hour fluid balance, favoring the treatment group. And I'm going to skip to this next slide. Renal replacement therapy was less. Mechanical ventilation was less in the treatment group, and length of stay was less in the treatment group. So there are studies out there that show there are some better outcomes when we do a stroke volume optimization approach. So I just kind of wanted to show you really quickly. I know we're still on those beginning guidelines about fluid, but I wanted to tell you how you can do this and kind of show you this in a case study format. So patient is 44 years of age. A female arrives in the emergency department with shortness of breath, stating she was diagnosed with COVID-19 4 days ago. Upon assessment, patient is found to be with low oxygen saturation of 65%, and despite high flow oxygen delivery and BiPAP, patient remained hypoxic, so had to be intubated. Patient's chest x-ray showed pneumonia, and the CT of the chest showed ground glass-like opacities, which would correlate the patient's recent diagnosis of COVID-19. So you can see here additional information. The lactate and blood cultures were drawn in the emergency department, and the patient did receive a liter of fluid in the emergency department. You can see temperature is elevated at 102.6. Blood pressure is low, MAP of 57. Heart rate's elevated at 135. White count elevated at 22,000. Lactate elevated at 8. BUN 30. Creatinine elevated at 2.2. And the procalcitonin was elevated at 4. So this is definitely a patient who is septic, right? So the patient arrives to the ICU. Non-invasive hemodynamic technology is applied to the patient to assess how we could better optimize. Now, I do want to just throw this out there. Why not try this in the emergency department? There are times where this could be very helpful. So our first question always is the patient hypotensive or hypoperfused? We know they are hypotensive, 57 MAP. So we're going to do a passive leg raise to assess for fluid responsiveness. The whole idea is that we want to know exactly how to best treat this patient. I want to mention these other parameters as well. Stroke volume is 40. Normal stroke volume is right around 60 to 100. So you can see that this is low. Our SVR is low. And cardiac index is only 2.1 with a cardiac output of 5.4. So when we did the passive leg raise, our stroke volume went from 40 to 41. I've done the math for you. It's simple calculation. 1 divided by 40, you get 2.5%. So is that 10% responsiveness or greater? No. So fluid is not necessarily our answer here. So based on our clinical findings, what should we consider next? And I want you to think about this scenario and then think, would it be a vasopressor? Would it be an inotrope? Would we give more IV fluid or start a vasodilator? Hopefully everybody is thinking vasopressor. We already did a passive leg raise and we did not have a 10% or greater increase, so we know fluid is not the answer. So this patient has a low SVR and stroke volume is low. So we're going to go ahead and give the patient, start the patient on norepinephrine. So norepinephrine is infused. It started at 5 mics, and over the next hour, we increased to 20 mics per minute. So our question now is the patient still hypotensive or hypoperfused? Temperature is a little bit better. Heart rate's a little bit lower. MAP is better, but it's still less than 65. Stroke volume's better, but we're still low at 45. And SVR has increased a bit, and cardiac index has come up a bit. So our question is this: what do we do? Well, if our patient is hypotensive or hypoperfused, which they're still hypotensive, then we're going to do a PLR test. So we did a passive leg raise. We went from 45 to 49. I've done the math for you, and it's only an 8.8% increase. So my question for you all is, based on our clinical information presented, what should we consider next? Do we go ahead and increase the norepinephrine more, or do you want to add another vasopressor? And we would add vasopressin. Do you want to give an inotrope, or give more IV fluid, or give a vasodilator? I'll give you a second to think about it. And you can see our stroke volume is still low, and our SVR is still low as well. And we're going to add another vasopressor. We're going to add vasopressin. So you see how this is working? We add the second line of pressors, and then our question is, whenever it's been a minute, we'll assess the patient after these changes. So notice pressors continued, blood pressure improved for the next hour, MAP increased, and TPR and SVR/SVR increased, lactate decreased to 4, but after 2 hours, the cardiac index dropped and the stroke volume decreased. So our next question is that patient still hypotensive, or are they hypoperfused? So let's look at our numbers. Our heart rate looks better, our temperature looks better, blood pressure looks better, it's 66 MAP, but our stroke volume is low and our cardiac index is low. So I'm going to say yes, this patient is hypoperfused. We have a very low cardiac index. So let's go ahead and do a passive leg raise and see if this patient responds to fluid. So we do a passive leg raise, and we go from 38 to 39 stroke volume. That's only a 2.6% increase. So we know that fluid is not the answer. So let's look at our options here. Based on our clinical information, what should we consider next? Would we increase norepinephrine, add another vasopressor, add an inotrope, give more fluid, or give a vasodilator? And the answer would be an inotrope. And the rationale behind that, you've got a low stroke volume, you have a cardiac index that's very low, and so this patient, and we know they will not respond to volume, and we already know that they're not ultra dilated, and they don't have a terribly low blood pressure, so vasopressors would not be necessarily the choice for them, but something to help with their contractility may be just the answer. So we started that third drug, and cardiac index did improve, as well as an increase in stroke volume. So that made us very, very happy. But 3 hours after we started that dobutamine, the blood pressure dropped. Stroke volume went from 50 to 42. And you can see that our cardiac index was better, though, at 2.3. So our question is the patient hypotensive or hypoperfused? Well, we have a MAP less than 61, so a MAP of 61. So yes, the patient is hypotensive. So we are going to do none other but a passive leg raise. We do a passive leg raise, and lo and behold, when we do that, our stroke volume goes from 42 to 48. This patient ends up with a 14.3% increase in stroke volume. So what do you think the answer is going to be when I ask what should we do next? And I hope that you all said give more IV fluid. And so that's exactly what we did for this patient. And you can see the patient was given a fluid bolus based on stroke volume response. If after the 500 ml of LR was administered, the new vital signs are listed. You can see the heart rate. You can see the MAP is better. Stroke volume's better. Our SVR looks decent, and our cardiac index and output looks good. So we are going to hold tight for the moment. I always tell my staff when I'm teaching and we have a scenario like this, that's the opportunity for you to take a bathroom break, right? Because you've been so busy. I will tell you that we have a nurse-driven protocol here at our institution. So if we have a patient that, whether they have an arterial line or they don't have an arterial line, if they're hemodynamically unstable, if they're on a vasopressor or an inotrope, or if we need clarification of fluid status, then our nurses can go ahead and initiate hemodynamic monitoring. All right, so that was resuscitation. Let's go on to vasopressors. We know that our vasopressor of choice is norepinephrine. That has not changed. That has not changed for 2021. What did change and what was documented in the guidelines, we suggest starting vasopressors peripherally to restore MAP rather than delaying initiation until central venous access is secured. So what I wanted to share with you, we actually developed a peripheral vasopressor policy. I don't know about you, but I was finding that it was happening. So I thought, if it's happening, then let's make sure we do this as safely as possible. And if the literature does support it, which we did find data that does support this, just like the guidelines wouldn't support it if we didn't, then we want to make sure we're safe. So I have put in the presentation how we do vasoactive drugs through a peripheral line. We have specific areas where we would like those to be put. We say that the IV always needs to be visible. We also made a little peripheral vasopressor label that goes on those sites as well. And then we document in the electronic medical record if they have any symptoms. And that's there for your guidance. Next is steroids. So for adult septic patients with septic shock and ongoing requirements for vasopressor, they do suggest using IV corticosteroids, but that's only for the patient, for the adults with ongoing requirements for vasopressors. And next we have antibiotics. So there was a lot of dialogue and information about antibiotics. It does mention for adults with possible septic shock or high likelihood of sepsis, recommending administering antimicrobials immediately, ideally within 1 hour of recognition. And I know for us at our hospital, our goal is to give antibiotics within an hour. But it does mention here for those with possible sepsis, we suggest a time limit course of rapid investigation. And if concern for infection persists, provided antimicrobials in that 3 hours. And patients also at high risk for MRSA, we recommend empiric antimicrobials with MRSA coverage. We suggest against empiric MRSA coverage if at a low risk. So knowing what those risks are. Another thing I want to mention is utilizing your antibiograms. So when at your institution, you should be looking at your antibiograms to determine, hey, what kind of sensitivities are we starting to show in this area? And what's interesting is the antibiograms might be very different. I know when I lived in Michigan, it was different. The bugs that seemed to be more prevalent than when I came to Tennessee. And looking at your antibiograms will help. And two, if your guidelines and your order sets have specific antibiotics in them, just making sure that those are always looked at every year with your antibiogram. I think that's really important. Source control, no change since 2016, just making sure as feasibly, as quickly, and as medically and logically feasible that we are determining where this infection is coming from. And then regarding our ventilators, no real big changes on the ventilator portion. We still want to obviously prone our patients with severe ARDS, and then that's not a lot of changes in that section. Now let's talk about strategies for timely treatment. Strategies for timely treatment. When you think about some things we can do, we talk about that hour one bundle. How can we get these items done quickly and efficiently? And so we're going to talk through that. So when you think about measuring that lactic acid level and also applying vasopressors if they're hypotensive, the first and most important thing is identification is key. Make screening as easy as possible. Try to make sure that's in the electronic medical record. It needs to be added to the current electronic medical record if it's not. I know that my hospital, nobody seems to like paper screening. So we started in paper years ago, but then we have moved to electronic. Also thinking about screening at triage. We talked about this just briefly, but also labs and triage. So can we get that lactate? Can we get blood cultures if we need to there? And then with our lactate and how we have to repeat the lactate, and I'm sorry that arrow was on number 5. I mentioned vasopressors, but that was for the repeat lactate if initial lactate is elevated. So making sure that you have some kind of a reflexive order to where you can do that. And do it quickly, and it will automatically prompt for you to get that lactate. And we do that, and that seems to work very well. And then thinking about real-time intervention that we've discussed, identifying some kind of a, whether it's a quality person or a real-time abstractor or coordinator, someone who can determine, hey, we need to make sure this patient is getting everything they need. Try to intervene to timely goals. I know one of the things we implemented was a code sepsis. So we have an emergent number, it's 5555. That we can call, and anybody house-wide can call a code sepsis, and there'll be a group of us who will intervene and help them with that hour 1 bundle with all of these items listed here. When you think about also then the other goal for broad spectrum antibiotics, having a hospital goal is really good, and knowing if your patient meets that goal. So ours is within 60 minutes, and we do track that monthly, and I let my staff know in the ICU. We had a staff meeting this morning, and I was telling them our time to antibiotic. And then another thing to think about is working with your local EMS. I've got an amazing EMS provider, Putnam County, and they really wanted to help. And so they will get blood cultures, and they will also give antibiotics in transport. Now, I'm a little bit of more of a rural hospital. There's probably no real big hospital that does anything that we do within about a 60-mile radius. So it may take patients quite a bit of time to get to us. So this is why it's so important that our EMS can help us out. Now, that doesn't mean we're willy-nilly getting cultures in the field. We track their contamination report, and we give them feedback. So they're doing a great job with that. Let's talk about decreasing readmissions. How can we decrease readmissions? This is a hard one, right? But I think with education and knowledge comes power. So trying to empower your patient to take control, to intervene early. And this is just one of the sheets. This came straight from the CDC, the What is Sepsis? And then we added a little URL code to that, so that they could, or QR code, excuse me, where they can actually go, and it takes them to watching a video about the importance of washing their hands, and giving them a video about what sepsis is that's more in like a cartoon kind of format. Another thing we have done at our hospital, we've got these sepsis fact sheets, and as well, life after sepsis fact sheet that we can give those. And once again, this is from whether it's Sepsis Alliance or CDC and Sepsis Alliance. There is a lot out there that you do not have to reinvent the wheel. You can just literally lift these from those areas, and it's very welcomed for you to use their forms. And we use these as well. Another thing that we have done or have are working on, we have a transition of care nurse that does education. Now, she does education for high risk discharges, like probably our COPD patients and a variety of other patients, but I've asked her to see the sepsis patients. So prior to discharge, one of our nurses will meet with our sepsis patients, and they will give them sepsis education. They'll also tell them, hey, what is it that if you have this, this, and this, you need to seek care immediately. So talking through them, what does sepsis look like, right? And how to intervene early. Now, we don't necessarily always want them coming to the emergency room, right? But teaching them how to catch it early enough to where they're not so bad, to where they can still see their primary care provider. And then as I'm going to, as I do community education, as I try to teach some of the community people how it's so important to think, is this sepsis, and use those words to the doctor. Say, could this be sepsis? And I think that is something to where it might catch the eye of the provider and say, oh, could it be sepsis? I think it's really important. Another thing we've started here at Cookeville Regional is a support group. And we kind of batched our post-critical care patients as well as our post-sepsis patients into this support group. And so we've said, have you been affected by sepsis or been hospitalized in the critical care unit? Then we have a group, and we're meeting virtually right now, and they can just scan their little QR code, and they can on their smartphone, or they can call in a number. And I love the mission statement to create a group where stories are shared, compassion is shown, and recovery is strengthened. And we decided, I know that the Sepsis Alliance has a support group, a virtual support group as well. We wanted something kind of homegrown to where we could just give support. I have a psychologist who joins me on that meeting, as well as a social worker, and then myself. And it's just once a month, and we are there to help navigate with them how they're doing, and just see what kind of support we can be for them. Another way to think about decreasing readmissions, just thinking about reaching beyond the hospital walls. And we already talked about partnering with the EMS, but also what about partnering with your primary care physicians and medical and surgical homes to educate on severe sepsis? What about partnering with extended care facilities and home care? And I know Pat Posa, she has done a lot of work with these extended care facilities as well. In fact, she shared all of her information, and I was able to use much of that. And we share freely. So if anybody has anything that would help you, that you need to help you, we're happy to share. But we really want to, I'm going to share with you a story about how we worked with some of our home health care as well as our nursing homes. And right before I do that, I want to also mention partnering with past patients and learning from them. I've started adding to our sepsis meeting a past patient, and I'll just bring them on virtually for the beginning of our meeting, and I'll let them share their story, and I'll have them, we'll listen to what they have to say, and we'll ask them, what is it we could have done better? And I am telling you, some of the stories they've told us, we've been in tears with these past patients as they're sharing with us. They're so grateful to be alive, but they're also sharing with us some sad stories, like maybe something somebody told them. So things that we can work on as well. This right here, I mentioned I was going to share with you our protocol for Putnam County EMS. This is the protocol, the flow chart that they use. And I'm going to tell you that when I started working with EMS, I was so impressed. They switched what they have in the rig. They used to always have dopamine. They switched it to Levofed. They never carried antibiotics, and now they have 2 different antibiotics. You can see the antibiotic choices. And then they started a system where they would call in a code sepsis. And one of the things they looked at was suspected infection and any 2 of these SIRS, or organ dysfunction. So if the MAP is low, if the heart rate is higher than 90, respiratory rate greater than 20, altered mentation from normal, and then they look at the end-tidal CO2. If it's less than 26, they look at that as kind of a surrogate lactate, right? And they declare a code sepsis if those are present, and they notify the hospital. They can do blood cultures ×2. They can give a fluid bolus, and notice they give LR. They can give antibiotics. They can reassess, and they can also, like I said, do blood cultures before they give the antibiotics. And we've been very clear about the plan. We never want them to go ahead and give the antibiotic if they can't, if they haven't tried to get the blood cultures. But anyway, it was just a blessing to work with them, and they were so willing to help. Lastly, I just want to share another item that we've done. We had an Upper Cumberland coalition where we invited anybody from the area, our nursing homes, our home health cares, and we just brought them into our hospital, and we gave them lecture after lecture about different things like infection prevention. A lot of this was infection prevention, whether it was mouth care, whether it was central line care to reduce CODI, to reduce CLABSI. And you can see we tracked, and this was back in 2017, we tracked it. We had 147 patients that were discharged with a sepsis diagnosis and were readmitted. Now, this is both inpatient and observation included, and this was during April to June. And what we found that 40.8% were readmitted from home, 28.6 though were readmitted from home health. 27.9 were readmitted from skilled nursing facilities, 2.7 from rehab, and 6.8 of the readmits expired. So we realized that, we have an opportunity with home health care and with skilled nursing facilities. And one of my skilled nursing facilities specifically developed, and this was our signature Putnam, that's their name, they developed a screening tool. And so they changed their whole process regarding their patients in the nursing home. And so on admission daily and with change of status, they determined which wing they were going to start this on. And if the patient has a known or suspected new infection, if yes, they would explain, and they even had examples in there: catheter, peg tube, incision, etc. And then they have to review the elder's advance directive prior to calling the doctor and to check all that applied. So they were looking at SIRS criteria and then looking at their organ dysfunction. And so they would reach out to the provider. We talked with them about being able to give fluids and giving antibiotics there in the nursing home. So it's just one way networking, working with your nursing homes to see if they can kind of change their focus to, hey, a daily assessment. Even though that is the elder's home environment, it's still an institution where there's a lot of people and they're elderly, so they're higher risk. And then recently had a home health care agent that reached out to me, and they want to partner and they want to do a sepsis program with their home health care patients. So I think there's a lot we can do in that arena. And these are just a few of the ideas, a few of the things we've done. But I do want to make sure we have time for some question and answers. So I am going to summarize by saying, keep up the good work, keep working hard, keep being creative, keep trying to decrease readmissions, and let's all learn from each other and share freely with each other. And with that, I'm going to turn this back over to our awesome moderator and friend, Pat Posa.
Wow, thanks, Angela. That was a phenomenal presentation, giving us a great update on the current state of sepsis and where we have opportunities, and then how to go beyond just in-hospital focus and to partner with extended care facilities, home care, and stuff. Before we move on to the questions and answers, I want to just review again how to get continuing education. Again, this webinar is approved for a 1 contact hour, and you can obtain these continuing education credits by logging on to www.saxtesting.com. You'll register, complete an evaluation form, and when you successfully submit that evaluation form, you'll be able to print your certificate. Just a reminder, this activity was supported by an educational grant from Dale Medical. And the CEs are for nurses and respiratory therapists. There's also going to be available an archive or an on-demand version of this presentation, and that's on www.perspectivesinnursing.org. And an email will get sent to all registrants when it's available, and those will also be accredited for CEUs. So now we have time for questions. And so keep the questions coming in. Our first question, Angela, is in relationship to pregnant patients. All right, so are there special considerations for pregnant patients, labs, specifically lactic acid, depending on where they are in the delivery cycle? And then how do you take into consideration the normal physiological changes in pregnancy with sepsis?
Yes, that's a great question. So there are specific changes for that, the patients who are they're in the process of giving birth or prior to giving birth. So for our sepsis patients down in the for the OB area, our SIRS criteria are different based on the maternal changes in the patient, and our lactic acid results are a little different. When I spoke pretty broadly about the general patient, but yes, there are some differences, some changes. I'm happy, whoever said that, if you want to email me, I'm happy to send you a copy of what our screening looks like for that maternal area. We've always screened in that area, but we've recently just updated with the latest. I know CMS has specific criteria as well, and we have changed to that criteria.
Also, Angela, I know that there's a coalition in California that has done a lot of work on screening and implementation. And so they have a toolkit that's readily available. And I don't have it right off the top of my head, but maybe we can include a link to that in an email that gets sent out. But it really specifies specifically that physiological changes, and not to use lactate during the laboring time, and so it's a well put together toolkit.
Yes, in fact, that is the toolkit that we use to update all of our items for too. So yes, it's a no-brainer. It's phenomenal. Yes.
Great. So another question, do you find that passive leg raise is more reliable or effective than a fluid bolus when determining responsiveness?
I don't know if it's necessarily more reliable, but I like it better because, well, I'll be honest, I don't have to have an order to do it, right? So I love nurse-driven protocols. But what I like about it is that I don't have the risk of, if they're not volume responsive, then I have to turn around and then try to get that off the patient, right? So it works well. We do it on a lot of patients. Now, there are going to be some patients that it's not appropriate for. I don't think my CV surgeons would be real happy if we have a freshly grafted patient who's just had open heart surgery, and that's probably not going to be the patients I do this on, but we do this on a lot of other patients, and it seems to work very well. We can do fluid bolus as well, but then you can't just, you have to give Lasix or whatever you need to do to remove the fluid.
You can't take it back, yeah.
Yeah, you can't take it back. That's what I love about good old gravity. Lower their legs, it's better.
So kind of along those lines, Angela, another question, when you're talking about passive leg raise and volume optimization, is this that include that initial 30 milliliters per kilogram, or is it the volume after that initial 30 that you really want to ensure you're optimizing?
Yeah, that's a great question. I think a lot of the literature, and you can speak to this too, Pat. I think a lot of the literature really does support that initial part, just giving that to them, that they typically will need that. I think for me, if a patient, and you speak up too, Pat, if a patient has, let's say, renal failure or heart failure, and everybody gets so nervous about giving them fluid, and if they're not sure if they can give safely that 30 mil per kg of fluid, then I think that's a great opportunity as well to utilize that to see, hey, are they responding okay? What are your thoughts? You've dealt with this patient population a lot.
Yeah, I think that even though the CMS guidelines are giving us exceptions to volume needs related to that 30 milliliter per kilogram, there's literature out there supporting that those patients in end-stage renal that are in sepsis really do benefit from getting that initial fluid. You take care of patients that are end-stage renal, they're kept dry as prunes, right? They are intravascularly dry, and now you tack sepsis onto that, where they physiologically are changing and have capillary leak and vasodilatation. They are hypoperfused, and volume is a significant portion of the reason for that hypoperfusion. So I think it's important to give that 30 and then use the passive leg raise and volume optimization to decide what after that. But if people are a little fearful, then, with the heart failure patients or the end-stage renal, using a device to monitor to see if they are fluid responsive prior to giving it is good, but there shouldn't be anybody that needs to go on a vasopressor that hasn't gotten some fluid. And so we want to make sure that we, don't swing that pendulum. Yes, over fluid is not good, but under fluid is also not good. And I know, Angela, you didn't have a chance to talk about all those harms from under resuscitation.
Yes. Good point. Very good point. I think of it like the Goldilocks principle. You have too much, you can give too much, you can give too little, you want just the right amount. So and yeah, I focus more on the over, but you're exactly correct. You can have under and be hypoperfused and hurt organs as well. So opportunities for sure.
In follow-up to the passive leg raise, are open heart surgery, are there any other contraindications besides open heart surgery that you wouldn't do a passive leg raise?
I think you have to think through this. There are some. What other types of patients? Big belly surgeries may not be a good choice. I think you have to look at every patient individually. I hate making carte blanche statements that, hey, you can do this on everybody. You can't, because there are going to be patients you can't. And so as I've gone into rooms and I've had nurses say, listen, they are just in too much pain. Their legs are horribly painful. This is not going to work for them. Yeah, I mean, I think some of it is common sense as well. And then some of it is based on what they've had happen to them. I don't know if you have more you want to say about specifics.
Yeah, no, I agree with you, Angela. I think that, someone with a large abdomen or open abdomen, someone, of course, if you happen to have a septic trauma patient, head injured, that you need to keep their head of the bed up for ICP, you're not going to do, passive leg raise. So, and someone that doesn't have intact lower extremities, right?
Yes.
Because you need to be able to get that blood flow from the lower extremities.
Yes.
We have a question about, aside from broad spectrum antibiotics, is the use of Alevin still encouraged for wound care and infection prevention? And I don't know. So go ahead, Angela. Do you?
Well, I think if you're talking about, we use Alevins all the time for pressure prevention. In fact, we have a protocol that if somebody's on vasopressors and also just in general, if they have a low Braden score, making sure that bony prominences, we put Alevins on. I don't know if that's what they're alluding to. But definitely anything prevention. That's part of infection prevention, right? We don't want an open wound. So making sure heels are offloaded, making sure that, patients are offloaded to where you don't develop wounds. I don't know if that's what they were looking for. But
okay. If the person that wrote that question, if you have any more clarifying, please put that in. Another question is, what did you hear from the skilled nursing facilities and nursing homes that they're doing that you like?
Well, I just was thrilled that they were checking vitals every day, right? Because that's not always the case, you guys. I don't know if everybody's aware. The culture is so different. In fact, I struggled a bit as I was in these, when I've worked in or gone in to see the process of a nursing home, but they have to remind me, this is their home. This is their home. This is what they do. Things are different versus the acute. But there are a lot of similarities from the standpoint of we're still an institution. You still need to have best practice, and that still needs to be implemented, right? So there were just a lot of things that they were open to. I like that they went to checking vitals and being more vigilant, and also actually screening their patient and coming up with dialogue to talk to their provider about, and be able to say, hey, we can give an antibiotic here, we can give them fluids here, we should not have to go to the hospital to get that. So I think some of those are real pluses.
Yeah, I agree. And as you alluded to, Angela, when I've done work with a number of nursing homes, we actually put them at least 100 facilities, and our focus was more the subacute area of the skilled nursing facility, but a lot of those interventions trickled over into the general nursing home population, and really focusing on what can you do to, it's so disruptive to have to go to the hospital, and you have the ability to do some of those things right there. And it's about the early, right? And so I think that they were looking for sepsis and putting that into their standard work or their standard approach each day, I think is vital. And that was great. A lot of them, had difficulty trying to draw labs and stuff like that, right? And they had to work to get IV antibiotics available and fluid, but they did it, which was great.
Yeah, and I think it opened up our eyes too. It provided a place for communication. So if we weren't getting the labs back to them in a timely manner, that was a great opportunity for me to help work with our lab to say, why is this? Or what can we do to expedite that?
Great. Well, we are near time. Lots of great questions, and it sounds like we got to answer most of your questions. And we want to thank you for attending this webinar. I wanted to remind you that immediately upon, I'm going to turn it over actually to Tracy, and she'll have some concluding remarks. But thank you so much, Angela, for the wonderful presentation. Thanks for the questions. And go ahead, Tracy.
Thanks, Pat. And again, thanks, Angela. We'd also like to thank everyone for attending today's webinar. A few key things. There will be a survey. So immediately upon the conclusion of this webinar, you'll be presented with an online survey. Please keep your web browser open, and we appreciate your feedback. As well as for the CE Certificate of Completion, in 1 hour following the conclusion of this webinar, you'll receive an email with instructions and this link to obtain your CE credits. That's www.saxtesting.com/paragraph P. And with that, this concludes the session. So again, we thank everyone for joining, and we hope you have a great rest of your day.